So welcome everybody to this PenARC Seminar, where we have the pleasure of inviting Eirini from North Thames ARC. Could you introduce yourself, Eirini? But we're really looking forward to your talk. Yeah, hopefully we will get our brains going and thinking. All right.
Well, thank you, Kristen. Thank you for hosting me for this. I am indeed I'm currently based at UCL, the Department of Applied Health Research, and I am a senior research fellow in health economics within ARC North Thames. I do have expertise in the economics of disability and economics of discrimination. I am an economist by background, as you may have guessed, and that's why I'm presenting you on childhood disability and disability more broadly today. And thanks to those of you that have joined, and to those of you who probably watch that a bit later. Okay, so the topic is measuring childhood disability in secondary survey data, evidence from the UK and lessons learned from international studies. You will understand a bit later why I've put childhood in brackets. It's because essentially what I'm going to talk about quite a lot. There is a lot of overlap between adult and childhood disability, particularly when we are focusing in the UK. There are some substantial differences when we are looking at international evidence, but I will explain that in more detail later on. The talk will be divided in 3 parts. So first of all, I will assume that you know nothing about disability or any conceptual or theoretical models of disability. That's why I'm going to give you a very quick overview of these. And then we're going to talk about the nitty-gritty stuff, as I often say, about what happens in practice. How do we measure disability and childhood disability in quantitative surveys? And finally, we're going to talk about what happens when we use different definitions to characterize disabled people or disabled children. How does that impact disability prevalence? With references both internationally and in the UK. So the first topic is, as I mentioned, is about some basic theoretical or conceptual models of disability. For those of you who are not familiar with the terminology, you can think of it as a set of terms that can be used to explain or to help us understand the concept of disability. But before going deeper into those models, it's important to remember and understand some key terms that contribute to those models. So by those, I refer to impairment, functional limitation, activity limitation, and participation restriction. So starting with impairment, impairment is characterized as the loss in bodily function that results from a health condition. So it could be an amputated limb, as I have here, or it could be, for example, a cataract. On the other hand, functional limitation refers to difficulties in core areas of function. So it could be issues with the ability to walk. You might have a paralysis in one of your limbs, or the ability to see. And then you have activity limitation, which is much broader than functional limitation, and it covers functional limitation plus other forms of activity in the environment. So it could be things like participation in civic activities or social events. It could be things relating to driving or using public transport. And finally, we've got participation restriction, which is a difficulty in being involved in different life situations. And I've listed here education or employment, but you could think of other, so participation in any community activities, for example. We know from the literature that impairments are typically required for someone to be characterized as disabled, but it doesn't mean that an impairment automatically imposes a restriction. And that there is a sort of quote here from a fairly recent paper that impairments do give rise to functional limitations, and put someone at risk of disability, at the risk of activity limitations and participation restrictions. So the first model that you might have come across, some of you, is the medical model. It's a model that places disability in the concept of a problem that results from a medical condition or diagnosis. So the emphasis is really put on a clinical intervention and rehabilitation. But this model does not take into consideration the influence of the society. The second model is the social approach, or the social model. In that, disability is not just seen as a medical condition or diagnosis, but rather as a failure of the policy, cultural and physical environments that accommodate any differences that the person experiences in terms of function. So the disadvantage, if you like, with this model is that it doesn't take into account the impact of the impairment. And the third approach that I would like to focus on today a bit more, and you will see I will mention that again and again when we look at the practical evidence in quantitative surveys, is the biopsychosocial model or biopsychosocial approach. You might have come across it as the ICF approach, which stands for the International Classification of Functioning, Disability and Health. So that approach, simply you can think of it as a mix of the medical and the social model. It integrates factors that are pertaining to both the individual and their environment. So it's not really about describing just the functioning of the person, but also placing that functioning into its social context. It has been characterized as the systemic and comprehensive way of conceptualizing the population with disabilities. However, as you might expect, there are other views that do lie between the two extremes. By that I mean the medical and the social model. And of course, there are other models that relate more closely, for example, to the Convention on the Rights of Persons with Disabilities. And I've put a reference here for you if you would like to read. It's a very long NIHR report, but it's really useful if you would like to gain some theoretical background knowledge on the various approaches. So we're moving a little fast, but this has quite a few details. I would like to make sure that we go through it in as much detail as possible. So we are going to look into how disability is being quantified in survey data. We are going to start with childhood disability, and we are going to also refer to some adult disability measurements, which sometimes are also being used to characterize childhood disability. And this is because really any attempt to characterize a person as having a disability or a child as having a disability, it's often a mess. So it's not a maze trying to find your exit way, but rather a mess, as you will see in a few minutes. So we know it's a fact that disability, adult disability, or even childhood disability in survey data is shaped by existing survey questions that unfortunately do vary a lot over time, but also across surveys and across countries. Another thing that we know is that disabled people can also be characterized by very narrow definitions, so which are focused more on the medical approach or the medical model or some clinical codes. And we also know that there is no methodology about how to collect data on childhood disability or even adult disability that is used globally and consistently. Particularly in regards to child disability, we know that historically any measures have focused on domains of physical and sensory functioning, but there are others also that focus on psychological functioning, but these are very limited. So the large focus is on physical and sensory functioning with less focus on psychological functioning. There's also the issue of stigmatizing or judgmental language when we talk about childhood disability. And there is also the methods that are used for data collection are often non-inclusive. Not just the data collection methods, but also the analysis. So, yes, defining disability and even childhood disability more specifically in surveys is not an easy task. So our first measure is fairly recent. You might have seen it before, but if not, we're going to explain it in detail. And apologies for the slightly wordy slide, but I try to incorporate as much detail as possible if you haven't seen it before. So this the slide is about child functioning module. It was a questionnaire that was developed by UNICEF and the Washington Group. It was finalized in 2016, and it's very closely linked to the biopsychosocial model that we talked about earlier. It can be used in censuses and surveys, and it covers children between 2 and 17 years of age. So these questionnaires, I refer to plural questionnaires because there are 2 questionnaires depending on the age of the child. The questionnaires are administered to the mother or the primary caregiver of the child, and there are 2 different types. One questionnaire that refers to children between 2 and 4 years old, and another one that refers to children between 5 and 17 years of age. The length of each of them is different, so we have a slightly longer questionnaire for the older children, and that is because it covers other domains that are not relevant for the younger children. I have listed here the different domains for the different age groups. So as you can see, for younger children, the areas that the questionnaires cover refer to seeing, any difficulties essentially with seeing, learning, hearing, mobility, and so on. Whereas for older children, you are covering the mental aspect as well. So issues, let's say, with anxiety, depression, or coping with change and relationships. I've tried to pick up a couple of questions for each of the questionnaires just to give an indication of how these things are being asked. So, for example, if we look at the younger group, there is a question that the parent or the primary caregiver of the child is being asked, compared with children of the same age, does the child have difficulty playing? Another one is picking up any issues with picking up small objects with their hands. And I've picked up here one question that refers to anxiety for older children. So how often does the child seem very anxious, nervous, or worried? Or does the child have difficulty with self-care, such as feeding or dressing himself or herself? So as you can see, the questions are not identical, as in you would expect different response options to those questions. So there are some that refer to the level of difficulty, and there are others about the frequency. So For those that refer to the level of difficulty, then the responses, the possible response options that you can get in the questionnaire are no difficulty, some difficulty, a lot of difficulty, and cannot do at all. Whereas for questions that refer to frequency, like the one I have here about how often the child seems very anxious, nervous, or worried, they have to respond with either daily, weekly, monthly, a few times a year, or never. So I have included the details for you here. If you would like to access the full questionnaires, these are available online. And also there is a syntax in different software that again you can find in the link that tells you based on the responses to each of those questions how you can identify a disabled child in either questionnaires. So this, I've seen this questionnaire for either groups of children being utilized not in the UK, but rather in other countries in the States. It's fairly frequent, but also in other countries like Pakistan, for example, or in African countries. There is a report that I've listed down here by UNICEF that has some evidence on the global studies that have been conducted using this measure. But as I said, from at least to my knowledge, this has not been used in UK studies so far. So the next measure, you might have seen it with regards to adult disability. So it's the Washington Group sort set, but it can be adapted to be used for childhood disability. That's why I've decided to mention it here, but I'm not going to go into too much detail. So again, that set has been developed by the Washington Group. It's internationally tested and is widely accepted. It's fairly short because it has 6 questions, and it can again be used in censuses and national surveys. It's focused on the biopsychosocial model or approach, as with the other module that we saw, and the questions are in the form of do you have any difficulty with, and then you specify the domain, and that is in this case vision, hearing, walking, remembering, self-care, and so on. And the response options are, because the questions are about difficulty, are no difficulty, some difficulty, a lot of difficulty, and cannot do at all. So the characterization of somebody as having a disability with this set is a bit simpler than the children one, because you can identify as someone being disabled if they have reported a lot of difficulty or cannot do for at least one of those 6 questions. Whereas for the previous one, the CFM, it's a combination of responses. It's not just you have said cannot do or a lot of difficulty in at least 2. You can see that if you check the code, the specific code, you can understand why it's a bit more complex than the Washington Group one. So I'm not sure if you have seen that before, but I was very glad to see that happening. There has been a global initiative which is led by the University of Fordham in the States, and they have a website where they list any information around disability that can be found in censuses and large household surveys globally. So great. When I saw that online, I was very curious to see what's happening with the UK. Is UK included? And if so, which sort of surveys are being considered? As you can see, UK, yes, it was considered as one of the countries, but there were no sort of surveys that were found relevant for this particular reporting. And I thought, okay, why that might be the case. So the choice of the definitions or the type of questions that this team considered when they extracted all those information to create the disability data report, as I mentioned earlier, was focused on the kind of the Washington Group type questions, and not so much on the questions that we normally use in the UK. And I have included here the census questions that were found in the recent survey, just to give you an idea why that was the case. So in census, we had two questions to identify a disabled person. The first one was, do you have any physical or mental health conditions or illnesses lasting or expected to last 12 months or more? And then there was a kind of a follow-up question, do any of your health conditions or illnesses reduce your abilities to carry out day-to-day activities? So if you recall, these are quite different from what is included in the Washington Group type questionnaire. So it's not so surprising why they haven't really identified any relevant questions or surveys in the UK that could be included in their reporting. But I thought I mentioned it here regardless, given that there might be a global interest in those of you attending. One thing to highlight also is that the surveys that they looked at, this team, were just not all of them available in the UK. So it was things like the Family Resources Survey, it was the General Lifestyle Survey or the Labour Force Survey, but there are so many others that might include disability or disability-related questions and perhaps could be relevant to this kind of reporting. Yes, okay, we know roughly what happens globally, but what's the story in the UK? The story is a bit of a mess. So we know from the literature that there are three established definitions for characterize the person as having a disability. However, there are several others, and the situation becomes even more complex when you try to distinguish between adult disability and childhood disability. So the first definition that is, I would say, is more frequently used so far in UK surveys, in the UK to characterize a disabled person, either that is a child or an adult, using secondary survey data, is the activity limiting disability. You might have seen it otherwise not mentioned as global binary indicator. And that incorporates two questions. The first one is, do you have any long-standing illness, disability, or infirmity? And there is an explanation by long-standing, I mean anything that has troubled you over a period of time or is likely to affect you over a period of time. Then the individual can say yes or no to that. If they say yes, then they are asked a follow-up question, does this illness or disability, or do any of these illnesses or disability limit your activities in any way? So either the parent on behalf of the child or the adult respond yes to both questions, then they are treated as disabled. If they say yes to the first but no to the second, then they are treated as non-disabled. And if they say no to the first, then they are not asked the second, and they are treated as non-disabled. So this is the first one. As I said, this is the most frequent one. Then we have a work-limiting disability. So this, the wording of those questions reflects the adult work-limiting disability, but in thinking about children, then it could be with regards to school activities, for example. So the first question is, do you have any health problems or disabilities that you expect will last for more than a year? Again, note the period of time here, more than a year. And then they say yes to that. Or no. If they say yes, then they are being asked, does this health problem affect the kind of paid work that you might do? Again, they can say yes or no. And there is a third question that again relates to work activities. Does the health problem affect the amount of paid work that you might do? So if you respond with yes to all three, then you're treated as work limited disabled. If you respond yes to the first, but no to the other two that relate to the work limitations, then you are treated as non-work limited disabled. Just going back to the point, if you were thinking about childhood disability, then these activities would refer, for example, to any school-related activities and could be adapted accordingly to capture those children with disabled children with limitations in doing certain school activities. And kind of the last one, well known, is the one that directly links to legislation, anti-discrimination legislation. I've listed here the Disability Discrimination Act as an example. And that is because in the Equality Act, the wording was slightly changed. So according to the Equality Act, you are considered to have a disability if you have a physical or mental impairment that has a substantial and long-term negative effect on your ability to do normal daily activities, which is slightly different from the wording that we have here. So they have sticked a bit more to the DDA wording these questions. So the first one is, do you have a physical or mental health condition or illness that has lasted or is expected to last 12 months or more? You can say yes or no. If you say yes, then you have a follow-up question. Does a condition and or illness reduces your ability to carry out day-to-day activities? Again, if you say yes to both questions, then you are treated as disabled. If you say yes to the first but no to the second, then you're treated as non-disabled. Something to point out, and you might have already seen that, is that the activity limiting disability, the top definition, does not clearly distinguish between activity and participation restrictions, although it has been used more frequently in the literature. But then you might also come across more direct questions. These are less frequent, but albeit they can still be found in surveys. That's why I thought I mentioned them here. As I said, they mostly cover adult population, but I thought I still include them here. The first one is, are you or is the person registered as a disabled person or as visually impaired with the local council or social services? And you can say yes or no. And then the other one is, do you think yourself as disabled or do you consider yourself disabled? Again, these are fairly very, very direct questions. Of course, there are questions that might relate to disability benefits. So do you receive any specific benefit? And again, that's another option, another potential measurement that can be used to identify a person as having a disability. However, these questions are often poorly responded. So you have several missing data, and it's also the case that respondents might be afraid that by responding truthfully, if you like, to those questions, maybe not have access any longer to those benefits. So that there is a high chance of misreporting to those specific benefit-related questions. But for children, we can also have other measurements, which makes the situation even more complex in surveys. So you might have questions that relate to special education needs, or SEN, which can be used to characterize a child as having a disability. However, those questions refer to certain age groups, so you might be missing the younger or kind of the older children out because the questions do not apply. And you might also come across some developmental delay questions that relate specifically to motor coordination and early communicative gestures. Again, this can be used to as a proxy to identify a disabled child. But again, there is the issue with the age restriction for those questions, as they may not apply to older children. So in the UK, there are three, I would say, up to three main surveys that have used, and I am aware of, that have used the SEN and the DD, developmental delay approach, together with the activity limiting disability to characterize children with disabilities. So to give you some examples of those surveys, you might have seen them before, is the Millennium Cohort Study is a very famous one, and the other one is the longitudinal study of young people in England. And they try to gauge the prevalence of childhood disability from those surveys using three measurements. You might, the question you might have is, okay, yes, there are three measurements. Do they overlap? Do we get similar findings? I'll come back to this in a few slides later. But as you can see, in the UK, there is no, is a bit all over the place. So there are several, at least three definitions that are used to characterize either an adult or a child with disability. And it really depends on the study, on the aims of the study, to identify which is the most relevant, if you like, definition. But does really the definition matter when you are considering disability prevalence? As we will see, it does matter. And it does matter for various reasons. It could be that the perspectives are different. So it could be that for some of the questions I mentioned earlier are perceived by a disabled person as identifying them as having a disability, but by others, they may not. It's also the different definitions that are used in the UK and globally. In the UK, we don't use as often the Washington Group. Instead, we prefer other definitions like the global binary definition or the legislation related definition, or we use more practical measurements such as for children, for example, such as the developmental delay one or the SEN one, and the definition does impact on the prevalence. So I was looking into the existing evidence that has examined how does disability prevalence differ by the measurement that has been used, and there is an emerging literature. These are just some very recent papers that come from the international literature, and I have listed all the references at the end if you would like to look into those in more detail. In the UK, I was interested to see what's going on. So these papers refer to adult disability, but then I was interested about, childhood disability, given the interests in the group for this talk, and there's not much. So I was able to find these kind of three reports, if you like, and there was one sort of working paper or research brief, but there was not much. So the disability measures that were compared, I just picked a couple of studies from the international literature and one from the UK. These are just indicative to give you a sense of what they are comparing and where the differences might be lying. So the first one is from Denmark, and they are comparing the Washington Group sort set questionnaire with the global activity limitation indicator. So what does that mean? So that study, it was done in Denmark with Danish data, and the question for the global activity limitation indicator was, for at least the past 6 months, to what extent have you been limited because of a health problem in activities people usually do? And would you say you have been severely limited, but not severely or not limited at all? So that resembles quite a bit the activity limitation definition that we talked about earlier. But what you can see is that the different timelines. So previously it was at least in the UK, we use the past 12 months, whereas in Denmark, it's the past 6 months. But that often reflects different legislations across the different countries. The second study was done in Australia, and they also compared the Washington Group with a binary disability question. So that was a slightly different worded question. So do you have a health condition or disability that has lasted or is expected to last 6 months or more, and that restricts your everyday activities? And the response options were yes, no, prefer not to say. Again, as you can see here, the timeline is last 6 months. So you will see a similar timeline in New Zealand surveys as well. So it's 6 months, not 12 months that we normally have in the UK. So the first two studies were about adult disability. And the last one is let me go back one step, is this paper here, is a UK evidence, and they are comparing the long-standing limiting illness question, which is the same as the activity limiting question, and with the SEN and developmental delay. But what do they find? So with regards to the adult disability, when they are comparing the Washington Group with either of the two sort of global activity limiting questions, they did find that the Washington Group short set is likely to capture functional disability. The global activity limitation question captures a more restricted version, because you are asking questions that relate more to physical difficulties. Another thing is that the Washington Group does not have anything about the duration of the health problem. There is no timeline. You are asked about your current status. And there are no questions that directly relate to mental health issues. And they did find, so they didn't just look at the prevalence, but they also looked at whether the different measurements impact denote a different demographic group. And they found that there were no significant or demographic differences when you are comparing the Washington Group with the other measures, but there were substantial differences in the population when you are looking at certain health profiles. And for childhood disability, surprise here, I guess, they used data from the Millennium Cohort Study, because you had all these three indicators in the survey, and they found a very little overlap between the three measures. So off the top of my head, I think it was about a third of positive responses to either of those measurements overlapped. So it's fairly low, but then at the same time, if you think of the types of questions that each of those measurements capture, then it's not so much of a surprise. I guess it's more food for thought for us. Okay, which one do we use? What is the study about? And what do we want to know really by using each of those measures together or separately? But there are other factors that can influence differences in disability prevalence. So it could be things like data processing. So what do I mean by that? I refer to things like how do I account for missing data in the questionnaires. So you can consider imputation methods or weighting in terms of how in terms of data sampling. Then you can have also some context effects or priming. So it could be that in one survey, the disability or disability-related questions are being asked, for example, before some health-related questions or specific health conditions questions, whereas in other surveys, those questions are being asked fairly late in the survey. So does the order or the position or the location of those questions influence the disability prevalence? Then it can be and there is a study, it was literally just published last month, that looks into context effects and more priming using US data. And the last, I guess, factor that I could think of, at least, and I could find in the literature is also sampling. So sampling error or survey non-response, issues with under-reporting or measurement error. Again, that can arise due to the different sampling processes in each of the surveys. So this was really my last point here, and I would like to close with some important points and food for thought for you, for me, for others who would like to work in this area. As we saw, there are several theoretical or conceptual models that relate to disability. There are some that are more prevalent than others. For example, the biopsychosocial approach has gained popularity over the last few years, and it's sort of the preferred, I guess, approach from when you're using the Washington Group sort set questionnaire. However, it's a challenge when it comes to identifying or characterizing someone with a disability in survey data, either adult disability or childhood disability. We saw that there can be an overlap in the measurements between adult and childhood disability, particularly in the UK. There is no, if you like, a gold standard or there is a common measure, but it doesn't mean that that's a perfect measure or that's the right measure. There have been some attempts to harmonize the questions and try to make that wording more consistent over time, but we're still a long way to go. And as you saw, the evidence with regards to childhood disability is very scarce, particularly when you're looking at how do the different measures impact on the prevalence. And the choice of disability measure does make a difference. It can impact on some sociodemographic characteristics, as we saw in the papers I talked about earlier. That didn't impact in that case, but it could be in other studies. But it significantly impacted on health profiles. And on top of the measurements, there are the different measures that can be used. There are factors that relate more specifically to the data or the survey design per se that can influence the prevalence. And these are things that relate to, for example, how the data is being processed. Are there any missing data? Is my sample representative? Do I need to use weights? are these the questions that I'm considering from the different surveys asked at the same time in the questionnaire, or are they asked differently? Is there any priming or not? And how does that influence the prevalence on top of the different measurements that are used? So that's all from me. I hope you found it interesting. It was a lot of information, I acknowledge that, but I tried to be as inclusive and as possible, given that particularly with child with disability, the evidence is very, very, very limited.
Right, thank you.